Thank you very much for inviting me. I think this is my first time at this event. So I do have lots of different hats, and so I did run the Encef UK programme grant, and I'll give you a little bit of information from that, but not too much. What I was asked to talk about was infectious encephalitis causes and diagnosis, which is a lot to cover in 25 minutes. So I'm not covering it all. I'm going to say what is encephalitis. Now, the vast majority of you will probably already know this, but there is a reason why I start off with that. And then we'll talk a bit about infections, because that's obviously what I do day in, day out as an infectious diseases consultant, and then how we make the diagnosis. And again, I'm not going to go into a lot of details because there's a lot to cover. So why did I say what is encephalitis? And probably because there's a big misperception in the general public. You're a different kind of public, okay? And because you know more about it than the vast majority of people. They confuse what the difference is between meningitis and encephalitis an awful lot of the time. And dare I say, so do an awful lot of my colleagues. And there's a lot of lack of understanding even in the healthcare profession. Meningitis is the inflammation of the lining of the brain. People have headaches, they have neck stiffness, the lights bother them, but cognitively their thinking is okay. They're not confused, their conscious level is usually not decreased. Whereas encephalitis is inflammation of the brain tissue itself, and depending on which bit of the brain is inflamed, then depicts what symptoms people will have. So they may have very subtle changes in their personality and behaviour, which if a doctor doesn't ask other family members, may miss because they might look completely fine on that initial consultation. Hence why families and relatives who are here, it is so crucial that you come with relatives to hospitals to say, no, they're not right, there's something definitely wrong here. And sometimes they have fits and seizures, sometimes they have other obvious abnormalities like weaknesses of a limb, and can be confused for being a stroke. It's difficult for clinicians, so do feel sorry for them, okay? Because there's a lot of overlap with encephalopathy, which is that there's something else wrong with the rest of the body, but they're a bit knocked off, so they are confused. So you can have a really serious infection and be a bit confused. That doesn't mean to say you've got inflammation of the brain tissue or encephalitis. So there is a lot of overlap, and it can be difficult at that very first consultation to know the difference. What causes encephalitis? I've broken this really simply. So antibodies on one side, infections on the other. And I've only put up 1, 2, 3, 4, 5, 6, okay? There's a whole pile of different bugs that can cause infectious encephalitis, and I've not put the list. If I give you the guidelines, the list goes on and on and on and on. But the big one in the middle, HSV, is the commonest cause. So that's the one, that's why I've put it centre stage. But there's a whole pile of others, and I've put some in there on purpose. Measles, and vaccination rates going down. We're seeing more measles cases. Intravirus is very common. Rabies, I'll talk about that a little bit later on, listeria. But, and I'm going back, this is an old slide, but it does show you, does the mouse work? Yeah. HSV encephalitis is the biggest, commonest cause of sporadic encephalitis. That's why we talk about it first and foremost. And then we've got lots of other little ones here as well. This is an old slide, and at that time, a lot of them weren't diagnosed. Then Public Health England, back then it was called Health Protection Agency, did a study in 3 geographic areas. London was one of them, the southwest, and in Liverpool in the northwest. And they looked at the different causes of encephalitis. And, no surprise, HSV encephalitis was still the commonest cause for the infectious ones, but this is when autoimmune antibodies started to be developed or identified as being a bigger cause. In this particular study, there was a lot of TB overlap, there was also VZV. And just pointing out on this slide, this study was adults and children. So there were other autoimmune-mediated types of encephalitis in this, like ADEM, that happens more in children than in adults. The study that you've just heard Philippa talking about was this one. It was a big programme grant that I did, and it looked at encephalitis in adults and in children, and the only reason I put it up is to show you that HSV, this one here, is still the biggest cause of those infectious types of encephalitis. So all of these are infections, This was a big mixed bag. Most of this was VZV, the chickenpox virus, but there was lots of other ones, travel-related. There were immunocompromised patients in there with some weird and wonderful viruses as well. You have some bacteria, and then this chunk was the autoimmune. It looks like it's more proportionally than the previous study I showed you, but the definition's changed. So it's not actually more when we break this down into specific antibodies. And we still have a chunk that we don't ever find out what the cause is. Now, sometimes I look at these case records and I think, oh, that sounds really much more like a viral encephalitis. We just never identified. And others I think, no, it sounds more like an autoimmune type. So you can get a feel from the story. So talking about HSV, like I said, it's the commonest one. The vast majority of us in this room have probably had HSV when we were children. And we're very good when we're children. We share lots of things when we're children. We don't have very good hand hygiene. So we share all our bugs with each other. And we'll have acquired it. And we won't even have known it because there won't have been any infection at all at the time. And we will then, the virus will go up into the dorsal root ganglion, which is a part in the spinal cord where the nerves go, and it just goes there asleep, and it stays there. Until every now and again it will wake up, come back down the nerve, and usually will come to the lip and cause a cold sore. Every now and again it goes up the other way. Instead of coming down, it goes up, and it goes up into the brain. We don't know why. For some people who are unlucky, that the virus starts to multiply and go back up into the brain, and that's where you get encephalitis. You get lots of inflammation. You got lots of white cells that go into where the blood vessels are, and you get some bleeding in and around here. So this is hemorrhagic, and there's cuffing around these blood vessels. And this person obviously has passed away from their encephalitis, and there's a section of their brain, and you can see how much bleeding has occurred around where all that inflammation has happened in this temporal lobe. So this is this part of the brain. Patient journey. I love this slide. I put it together because every person has a story, and every person's journey is different. And understanding how people get to places is really important. So you can be unwell, but maybe talking with your friends and family, and you're not quite right, but you don't go and get any help. But other people will go straight away to get help. The different symptoms that people have, some will seek help quicker than others. Where do they go for help? Well, you might just go to the pharmacy and get some paracetamol because you've got a temperature. You might go to A&E, you might go to your GP. You might bounce back and forth between GP and back home again because they think it's just a viral infection. Once you get into hospital, then there's a number of investigations that should happen, but there's difficulties in recognising the symptoms that people have, and so there might be delays here, and it's easy to say this is what should happen, but it doesn't always happen the way it should. And then there's a number of investigations, and we'll talk about that. And there are different outcomes, and people can bounce back and forth. Their inflammation, like an autoimmune, might come back, and they have more and more problems. And I like this particular sub-study. This is one of my colleagues, Jessie, who interviewed patients who had HSV encephalitis. This is only the herpes simplex group. And they were very open-ended narrative questionings about their experience. And she was not a clinician. So she just let people talk about how they were feeling before they came into hospital, what their experience in hospital was like. And I've only taken 2 little snippets. And I've used lots of these snippets in different scenarios for different reasons. But for this one, I've highlighted in green just some of the wording that people use and how you can see it's vague and it's difficult to understand as a clinician actually what is going on. There's lots of different things that this can be. Unwell and a bit wobbly. You know, assessed for a stroke. Okay, then they're drowsy. He's not right. This is why I harp on about listening to family relatives. Strange symptoms, tripping over. Again, this assumption that this could be a stroke. This gentleman was in his 70s. This one was in his 30s. You can see how things can get clouded when people look at an age of a person as well, and what's the likelihood of this being this particular condition or this particular condition instead. So the story is really, really important. And what Jessie did there was very open-ended narrative stories. We don't do that in clinical practice. What we do as a doctor is take a very detailed history, and it's a story. It's just a different kind of story. But we'll target a little bit more the questions and the symptoms, and when did they start, and what the pattern and evolution has been like. And the story will include also their past medical history, and I'll demonstrate why that's important, and their social history. So if we think about symptoms, you might have a fever, you might not. You might have a headache, you might not. You might be fatigued, you might not. You might be a bit irritable. Can you see where I'm going with this? Not everybody's the same, okay? The encephalitis will be different for different people, and it's not always barn door obvious. It's sad to say that if you are younger and knocked off cognitively, mentally, you come in, you have a fit, someone will think of encephalitis probably far quicker than if you are older. And if you're a bit confused, because they'll say, oh, well, maybe they've just got an infection and they're a little bit of dementia and it's a bit worse. Okay, but if you've never met that person before, you wouldn't know that actually normally they're crystal clear and they don't have dementia. So there is this, again, and back to the relative being there to say, no, they're not right, this isn't what they're normally like. Okay. One of the most recent diagnoses of encephalitis I made was in a lady who had dementia, but whose husband said to me, well, yes, she's got dementia, but she's changed, she's definitely different. And by the time I got to see her, everyone else was treating her for a urinary tract infection. And then I said, no, let's do the lumbar puncture. And she did have encephalitis. So it's all important, even with someone who has got problems with their brain function, like dementia, still not to assume that they can't have encephalitis as well. The past medical history, so the story about what's happened before is really important. Okay, and this is why infectious diseases doctors take ages taking their histories, because they go back a long, long time. So if someone has had measles in the past, that's important to me, because measles does have other sequelae that can happen later on in life. You can have an encephalitis at the time of the measles, but you can also have one up to 20 years afterwards. So it's important to tell me if you've had that. Likewise, chickenpox. There are different types of encephalitis you can get with chickenpox at the time of the rash. In fact, I think it's on my next slide. You can get one that happens at the time of the chickenpox, or you can get one that happens a week later, or many weeks later. And those patterns are different if you're younger or if you're older. Again, for the measles, if it happens quickly at the time, you can have this primary measles encephalitis, but here you can have one that can happen up to 6 to 15 years afterwards. Sadly, if this one happens, people don't survive. Travel history. So one of my bugbears is people not taking travel histories. And we all go travelling for different reasons. We don't all go with our nice little suitcases and stay in lovely little hotels. Some people go backpacking and into the middle of nowhere and having the adventures of their lifetime and don't get any travel advice before they go and can pick up lots of different things when they're right there. And so I harp on to other doctors about taking a good travel history. And these are just a couple of acronyms that we use. But I'm really pernickety, can you tell? I want to know exactly where you've been and exactly what you've been doing and who you've been doing it with, and that does mean all those details, okay? We do ask all those details. If you're visiting family and relatives, if you're going to a hotel, if you're going to the beach, if you're going to go to safaris, I need to know all of that information. I need to know if you've been vaccinated against various different infections or not, or have malaria prophylaxis and taken it. Okay, we know when you haven't taken it. And even you can get malaria, though, with breakthrough, even if you have taken it, so you can be forgiven, all right, even if you've taken it religiously. But it's really important for us to take that level of detail, because that's what helps us to diagnose those infections when you come back. So the story, where have you been? Well, if you go to this part of the world, and you might have had some contact with some horses, you might have West Nile virus encephalitis, you might have Eastern equine encephalitis. There's a few nasty encephalitis viruses over there that you can pick up. If you go over along this sort of route in the world, and if you go to Sweden, you go to Austria, even go to the southern parts of Germany, northeast of France, there's tick-bourne encephalitis if you've been up hill walking and things like that. So I need to know about that, and there's all the different risk factors that you can get for picking that up. And if you go to any of this part of the world, all depending on how long you've been in the country, what you've been up to, whether or not you've been in rural areas, and you've been anywhere near rice paddy fields, and these birds and these pigs, this is where Japanese encephalitis circulates in this life cycle. Human beings, generally, for all of these, are dead-end hosts. They don't transmit onward infection, usually. And I've just put up some nice, more lovely pictures. I do this to all the doctors to try and scare them. But it's important for us to think about where the risks are, because we often forget about risks. So you can go to Italy, Bet you didn't think Italy was very risky, did you? So you can go to Italy and you can pick up sandfly bites and get Toscana virus, which can give you a meningoencephalitis. You can even get rabies in Scotland. That's where I worked before I went to Liverpool, and that was one of the first cases in the UK of a bat handler who got rabies lyssavirus. That was sad because he was actually a bat handler and should have known better to get vaccinated and didn't. So he passed away. There are a lot of people who go travelling who don't even think that they're going to be at risk of rabies and forget when they're down by the beach and those lovely stray dogs that come along, oh, I'll just pet this little dog. Nip, little bite, doesn't take much, and can come back and won't have anything for many, many months. And there have sadly been cases of patients coming back from their travels having had a dog bite or a monkey bite and got rabies. I've got the ticks and hill walking in Austria. There's lots of tick-bourne encephalitis there. Cats, even in the UK, can, if they scratch you, usually kittens or stray cats, they can pass on an infection called Bartonella that can cause an encephalitis. You can go kayaking around the river's edges. There's where the rats pee, and there's leptospirosis there. That can give you an encephalitis. Aedes, another type of mosquito, lots of different viruses. Zika was in the news not that long ago, again can cause an encephalitis. And there's lots of other viruses that these ones carry. Unpasteurised milk, I do like my unpasteurised milk, and I do like unpasteurised cheese, so I'm not saying you can't do any of these things, but you do have to know that there's risks involved with them. Listeria, brucella, they are in various cheeses in various parts of the world. Have I put anybody off going travelling? The next bit that's really important to us in the history is when you've gone travelling and whether or not it's at the height of meningitis season, going to the Hajj, for example. Is it at the end of a rainy season when all the mosquitoes have just been multiplying, there's lots of larvae everywhere, and then you're more likely to have dengue multiplying, things like that, and malaria as well. And then the incubation period. So I will add up. It's not good enough to tell me that you've been on holiday 3 months ago. I'll need to know exact dates, because the incubation periods for certain infections will say, right, it's not going to be that one because that incubation period is only a week. So arbovirus infections like Zika, like dengue, if you've been back for more than a week, that's not going to be the cause, and I can rule them out straight away. Things that take longer, incubation periods, brucella will take a longer time, TB will take a longer time. So that's why I harp on about the dates. And then how long you've been in the country and that exposure risk. So if you've gone to Thailand and you've stayed in a city hotel for a business meeting for 2 or 3 days and you come straight back, you're not going to have Japanese encephalitis. But if you've been backpacking and you've been going around in rural areas for at least 2 months or a month, doesn't have to be specifically that length of time, but a long period of time, and you're sort of exposed to those mosquitoes, you're more likely to be able to pick up Japanese encephalitis. So that's why the duration and exposure is important. Some of these are not wholly accurate, okay, because time has changed. So, for example, rubella, it says mortality not to 50%. That was one of the quoted papers that I had. That's because you have a huge variation when you have very little cases actually happening. But mumps, mortality is not that high, but look at the morbidity, the long-term sequelae that people will have afterwards. Likewise with measles, mortality changes as to when you get it, but the morbidity is very significant. Why am I harping on about those three? MMR. People don't get the vaccine of their children, and they're putting their children at risk of getting measles, mumps and rubella. And we've had outbreaks of measles. We've had them in the UK, we've had them in Europe, we've got them in the States at the moment, and I'm just waiting, sadly, for the outbreak of encephalitis to come with it, because I think it will come. That one we can vaccinate, so please do. Others, when you go travelling, get good travel advice, because there are a number of these that there are vaccines for that will prevent them. And if I could only show people what it looks like when they've had these and the morbidity that they have afterwards, I'm sure everyone would pay for the vaccine afterwards. But sadly, people weigh up the risks and their benefits when they're meeting a healthcare professional and think, well, I'll be okay. What's the chance of that happening to me? It won't happen. And there are others, there is no vaccine, so there's still research that needs to be done there. In terms of diagnosing, The main things that we do are taking a lumbar puncture, because we don't do brain biopsies, or very rarely, but we try to find the evidence of that inflammation somewhere else. So we get clues. If there's neutrophils, it's more likely to be a bacterial infection. If there's lymphocytes, it's more likely to be a viral infection. And then we look at them either underneath the microscope, or we get them to culture them, or we look at them in PCR methods, so different techniques of trying to find the infections. Sometimes we take pictures of people's brains and we might get clues. Again, none of this is barn door, because some HSV encephalitis might have normal brain scans, or they might have the classical signs in the temporal lobes. Here we've got Japanese encephalitis, where it happens in this part of the brain, the basal ganglia. Here you've got down at the back of the brain this rhomboencephalitis, which happens at the base, and this is where this inflammation is happening, and this is listeria for this particular one. Here we've got a child that had CMV encephalitis, and it happens around the rims of the ventricles, which is where there's lots of fluid in here. JC virus has a different kind of picture altogether. It has like a scallop appearance to it, and you can always have multiple bits. Here we've got VZV, again, inflammation of a particular organ right at the back, the cerebellum, that knocks off the balance, which is why children, when they get cerebellitis, they can't walk straight, and they walk very wide-based. All of these are clues, okay? There's nothing that tells any of us as clinicians which particular infection it is. The history will help point us in a particular direction. There's a lot of overlap with other conditions, and so we have to be methodological. I can't speak there, and go step by step to try and rule things out. Go with what's common and start investigating things. HSV is the commonest type, we know that, so that's why we jump in with the acyclovir, but sometimes it won't be that. But it's important we get in treatment really quickly. The longer you are at getting that treatment, the more likely you're going to do badly. So that's why we harp on about giving acyclovir quickly. It's very important, as far as I'm concerned, to take a good history, because the clues are always in the history, and especially finding out what you get up to and where you've been, what jobs you do, what sports and recreation you do, because there's lots of infections that you can pick up there. When we diagnose it, we don't do brain biopsies the vast majority of the time, so we're looking for clues in other areas. We're looking for those surrogate markers to tell us there's inflammation there. And one way I try to identify them, it's blood tests, it's CSF tests, looking for bugs in different techniques. Sometimes we do biopsies. TB, we might do a biopsy of a lymph gland and find the bug somewhere else. EEGs, again, these are the little electrodes on the brain that look at inflammation of the brain. They're not specific. They won't tell me exactly what bug it is, but they might give me a clue. So it's not as easy as it maybe we'd like it to be, and it takes a lot of detective work, which is why I do the job that I do. For my study, there was a lot of people involved, okay? It just wasn't me, and it was a big, big study, and the patients, you guys, were crucial for helping with getting the information and giving us the clues that hopefully will next help the next doctors in terms of helping other patients to know how to diagnose patients with encephalitis in the future. I hope that's been helpful.